Welcome to This Week in Oncology. This week we're covering 10 notable papers spanning long-term adjuvant therapy across breast, kidney, and lung cancer, radiotherapy dose and fractionation questions in prostate cancer, and new immunotherapy and combination strategies in liver, lung, and colon cancer. Let's dive in. We start with mature adjuvant data, where two long-running Phase 3 trials reported extended follow-up in Annals of Oncology. In Keynote 564, Haas and colleagues report the fourth pre-specified interim analysis of 1 year of adjuvant pembrolizumab after nephrectomy in clear cell renal cell carcinoma at increased risk of recurrence, now with a median follow-up of about 70 months in nearly 1,000 patients. Disease-free survival remained better with pembrolizumab, reducing recurrence or death by roughly 30%, with 5-year disease-free survival of about 61% versus 52% with placebo. Overall survival also favored pembrolizumab, with about a third reduction in the risk of death, and 5-year survival just under 88% versus about 82%. Median overall survival has not been reached in either arm, and safety was essentially unchanged. For a practicing oncologist, this is reassurance rather than a change, of course. The survival benefit seen earlier has not eroded with 5 years of follow-up, which strengthens the case when you counsel a patient about accepting a year of immunotherapy after surgery. Alongside that, Garber and colleagues report the third interim analysis of Olympiae, 1 year of adjuvant olaparib in more than 1,800 patients with germline BRCA1 or BRCA2 pathogenic variants and high-risk HER2 negative early breast cancer, now at a median follow-up of 6.1 years. Invasive disease-free survival, distant disease-free survival, and overall survival all continued to favor olaparib, with roughly a third reduction in invasive recurrence and a reduction in death of about a quarter, translating to a 6-year overall survival difference of about 4 percentage points. Importantly for the long-term conversation, there were fewer new BRCA-associated breast and ovarian or fallopian tube cancers with olaparib, and no signal of excess myelodysplastic syndrome or acute myeloid leukemia. The benefit held in hormone receptor-positive high-risk disease, which is exactly the subgroup clinicians most often question. Sitting neatly beside those data, the Journal of Clinical Oncology published the newest version of the ASCO Living Guideline on Medical Therapy for Stage 1 to 3 hormone receptor-positive, HER2 negative breast cancer, drawing on 45 randomized trials published since 2018, plus individual patient data meta-analyses. The framing is worth noting. Endocrine therapy remains the foundation, with chemotherapy and targeted agents layered on for selected patients, and the recommendations are now organized longitudinally, following the actual sequence of decisions from diagnosis through completion of systemic therapy, with a final section on estimating prognosis and absolute benefit. If you look after early breast cancer, this is the document to have open when you are integrating genomic assays, recurrence risk, and patient preference. Turning to prostate cancer, 2 randomized trials tackled radiotherapy dose and fractionation, and came to rather different practical messages. In the Lancet Oncology, Hennikin and colleagues report GETUG AFU 18, which randomized 505 men with high-risk prostate cancer, all receiving long-term androgen deprivation, to 80 Gray versus the standard 70 Gray of prostate-targeted external beam radiotherapy. At a median follow-up of about 9.5 years, 5-year progression-free survival was 91% with dose escalation versus 88% with standard dose, and the separation widened by 10 years, at about 84% versus 72%, corresponding to a reduction in progression or death of roughly 44%. Crucially, acute grade 3 or worse toxicity was essentially identical, around a quarter in each arm, and late grade 3 toxicity was around 7 to 8% in both. The authors are appropriately cautious given the small number of early events, but this addresses a genuinely controversial question and supports 80 Gray as an option even when long-term androgen deprivation is already on board. Then, in the Journal of Clinical Oncology, Song and colleagues randomized 316 men with biochemical recurrence after radical prostatectomy to salvage radiotherapy delivered either as 65 Gray in 26 fractions or the conventional 66 Gray in 33 fractions. Here, the primary endpoint was not met. 4-year biochemical progression-free survival was about 80% with hypofractionation versus 78% with conventional treatment, so hypofractionation was not superior. Distant metastasis-free survival and cancer-specific survival were the same, and patient-reported quality of life was comparable, but grade 2 or worse gastrointestinal toxicity was higher with hypofractionation, about 8% versus under 1%, concentrated in men who did not have an endorectal balloon. So the honest reading is that a shortened salvage course is a reasonable, convenience-driven alternative with equivalent cancer outcomes, not a better one, and rectal-sparing measures matter. In thoracic oncology, 2 Lancet Oncology papers address quite different points in the disease course. Lee and colleagues report Harmony, a double-blind phase 3 trial of ivonescimab, a bispecific antibody against PD-1 and vascular endothelial growth factor, added to pemetrexed and carboplatin in 438 patients with EGFR-mutated non-squamous lung cancer progressing after a third-generation tyrosine kinase inhibitor. Progression-free survival improved substantially, from a median of about 4.4 months to 6.8 months, roughly halving the risk of progression or death. However, overall survival, a co-primary endpoint, was 16.8 versus 14.0 months and did not reach statistical significance. Serious treatment-related adverse events were nearly twice as common with ivonescimab, at 28% versus 15%, and there were 4 treatment-related deaths. So this is a positive progression-free survival result, without confirmed survival benefit so far, and that nuance should shape how you discuss it. Meanwhile, Giadzusco and colleagues report the safety and quality of life outcomes from ALINA, comparing 24 months of adjuvant alectinib with 4 cycles of platinum chemotherapy in 257 patients with resected ALK-positive disease. Grade 3 or 4 events were uncommon with alectinib, dominated by creatine phosphokinase and transaminase elevations. Serious treatment-related events were less frequent than with chemotherapy, and discontinuations for adverse events were about 5% versus 13%. Patients on alectinib reported clinically meaningful improvements at 12 weeks in bodily pain, physical role, mental health, social functioning, and vitality, sustained across 2 years of treatment. That matters, because the main objection to 2 years of adjuvant-targeted therapy is the burden of taking it. Finally, 3 papers extend immunotherapy and staging into new territory. In the Lancet Oncology, Kudo and colleagues report EMERALD-3, which randomized 760 patients with embolization-eligible hepatocellular carcinoma to durvalumab plus tremelimumab with lenvatinib plus transarterial chemoembolization, the same immunotherapy doublet plus chemoembolization, or chemoembolization alone. With a median follow-up of only about 10 months, median progression-free survival in the triplet arm was 13.0 months. Overall survival data remain immature, so this is an early read on a combination strategy rather than a definitive one. In clinical cancer research, Shaw and colleagues report the NEST phase 2 trial of neoadjuvant botensiumab, an Fc-enhanced CTLA-4 inhibitor, plus balstilimab in 24 patients with localized colon cancer. Treatment did not delay surgery in any patient, and the major pathologic response rate was 41% in mismatch repair proficient tumors and 100% in the 4 deficient tumors, with immune profiling showing increased CD8 T-cell density and fewer regulatory T-cells in responders. Response in mismatch repair proficient colon cancer is the notable part, though these are small numbers in a single-arm study. And in the Journal of Clinical Oncology, Mercolini and colleagues studied 301 children and adults with FDG avid rhabdomyosarcoma who had both PET imaging and bilateral bone marrow aspirates and biopsies before treatment. Against marrow sampling as the gold standard, PET had 98% sensitivity and 90% specificity, missing only 1 case, while identifying marrow disease in 24 patients where biopsy was negative. The practical conclusion is that when PET shows no FDG avid marrow disease, routine bilateral marrow sampling can reasonably be omitted, sparing an invasive procedure, with imaging or biopsy reserved for FDG avid marrow lesions. If you only have time for one paper this week, make it GETUG AFU 18 in the Lancet Oncology. It resolves a long-standing question about whether dose escalation still adds anything when men with high-risk prostate cancer are already receiving long-term androgen deprivation, and it does so with a decade of follow-up and no toxicity penalty. Here are the key takeaways from This Week in Oncology. First, 5 and 6 year follow-up confirms that 1 year of adjuvant pembrolizumab in high-risk clear cell kidney cancer and 1 year of adjuvant olaparib in germline BRCA-associated high-risk breast cancer both delivered durable disease-free and overall survival gains with no late safety surprises. Second, in high-risk prostate cancer on long-term androgen deprivation, escalating prostate radiotherapy to 80 Gray improved long-term progression-free survival without added toxicity, while in the post-prostatectomy salvage setting, hypofractionation was not superior and carried more gastrointestinal toxicity when rectal sparing was not used. Third, adding ivonescimab to chemotherapy after progression on a third-generation EGFR inhibitor clearly delays progression but has not yet demonstrated a significant survival benefit, and it comes with more serious adverse events. Fourth, adjuvant alectinib's quality of life and safety profile supports the feasibility of 2 years of therapy in resected ALK-positive lung cancer. And fifth, in FDG-avid rhabdomyosarcoma with a PET-negative marrow, bilateral bone marrow sampling can reasonably be omitted. That's your roundup for This Week in Oncology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app, or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.